Dr. Evans is a social scientist with a background in public health and anthropology, and she has a long-term interest in ethics. She's an assistant professor at the Department of Ethics, Laws, and Humanities at Amsterdam UMC, and conducts research on complex decision-making in healthcare, aging, palliative care, and research integrity. Previous research projects focused on health and social care needs of elderly people living alone in rural Malaysia, patient-physician communication at the end of life, and the influence of culture on end-of-life care. So welcome, Nathalie.
Thank you, Melissa. It's my pleasure to present our Delphi study on psychiatric irremediability in the context of assisted dying. It's also my pleasure to present straight after Luke, because he was my supervisor 8 years ago on my PhD, and now I'm presenting my PhD student's work, Cisco Van Veen, who can't make it today because he's moving house. So I feel like there's some kind of cycle of knowledge here. Can you all see my slides in presentation mode? Great, thank you. Just to highlight, there's no conflicts of interest to disclose with the research team. And in this presentation, I'm going to give a little bit of background on assisted dying in the Netherlands, specifically for psychiatric conditions. I'll talk about our Delphi study on irremediability and some future directions that are related to that study particularly. So reflecting a little bit what Luke said, the physician-assisted death has actually been accessible for people with psychiatric conditions in the Netherlands since the 1990s. And the Dutch Psychiatric Association actually produced its first guidelines on the practice in 1998. However, until 2010, there were only a few cases each year. After 2010, these numbers have been rising, and this coincides with the establishment of the end-of-life clinic, which has changed its name to the Expertise Centre for Euthanasia. So this Expertise Centre was established to assist patients who wanted assisted dying, but could not find help from their own physician for whatever reason. So on the slide, you can see the total number of physician-assisted deaths due to psychiatric suffering represented by the green line, and all of the deaths that were performed by the Expertise Centre for Euthanasia represented by the black line. So you can see that although the numbers of deaths are rising, a very small number of Dutch physicians are actually assisting these deaths. So to give you a bit of an idea, in 2020, there were only 7 psychiatrists who were working in the Expertise Centre. So those outside of the Expertise Centre are very rarely performing assisted dying. And this might be because the legal criteria in the Netherlands, establishing the legal criteria in relation to psychiatric suffering is more difficult. So assisted death is still punishable by law in the Netherlands, but if you follow the criteria that were outlined in the 2001 euthanasia law, physicians can be exempted from prosecution. So this criteria is that the physician must be convinced that the patient is making a voluntary and well-considered request, that the suffering is irremediable and unbearable, that the patient must be educated about the situation they are in and their prospects, that the physician and the patient must be convinced that there is no reasonable alternative to the situation, that at least one other doctor must see the patient and give a written opinion on the above due diligence criteria, and that the assisted death or euthanasia must be performed in a medically prudent manner. So in bold, you can see the aspects that are particularly difficult in relation to psychiatric suffering. Also, there's heavy oversight of the process. So I said what the legal criteria are, and the Dutch Psychiatric Association guidelines are even a little bit more strict, which mirrors what Luke was saying about the situation in Belgium as well. So following the Dutch Psychiatric Association guidelines, the trajectory starts at the request phase. So the patient requests assisted dying from his or her psychiatrist. And in this request phase, there are important goals such as checking for suicidality, providing information about the process, and informing loved ones about the process as well. Now, if the request is considered reasonable, then they move to the assessment phase, where the physician investigates if the legal criteria are met and gets a second opinion from a relevant expert. And in this case, it would be a psychiatrist with expertise in the conditions that the patient is suffering from. So in this assessment phase, new diagnostic options and new treatment options might arise. Then they might move to the consultation phase, where a specially trained physician visits the patient, and this consultation focuses solely on the legal criteria, and in principle, no new treatment options can be given in this phase. And then there's the implementation phase, where physician-assisted death can be performed, and due diligence checks by a coroner and a review board, after which a judge will rule if all the legal criteria were met. So several studies, including case study analysis, surveys, and interview research, shows that psychiatrists regard establishing irremediability as one of the main challenges in this whole process. So in Cisco's PhD, he focused on exploring how irremediability specifically is established in practice. And he started with a scoping review and a qualitative interview study, which revealed important themes such as uncertainty, treatment refusal, and a retrospective view. So in relation to uncertainty, psychiatrists struggled with the level of certainty that is required regarding irremediability, because prognosis for psychiatric conditions is almost impossible to be certain about. Treatment refusal, because psychiatrists struggled with treatments, what treatments are reasonable for a patient to refuse, and if it is possible to even establish irremediability if a patient is refusing treatments. And that psychiatrists take this retrospective view. So irremediability is a prospective concept, but psychiatrists refer to retrospective aspects when assessing irremediability, such as a history of failed treatments. So there's certainly challenges in establishing irremediability, but we ask the question, are there criteria that psychiatrists can agree on in relation to establishing irremediability in practice? And to answer this question, we undertook a modified Delphi study, inviting Dutch and Belgian psychiatrists who had experience in assessing irremediability in the context of assisted dying. So the Delphi had 2 rounds. The first round started by asking the open question, how do you define irremediable psychiatric suffering? Then the experts were asked to indicate their agreement in relation to some diagnostic and treatment criteria, which had been put together by the steering group based on the previous literature, based on Cisco's previous studies. And they indicated their agreement on a 5-point Likert scale, and they were also asked to provide their reasons for scoring the criteria as they had in an open question. So criteria that reached consensus in the first round, and for which the comments indicated that they were well understood, were accepted, and they weren't returned to respondents in the second round. And criteria which had not reached consensus were adapted based on the comments given by the respondents, and they were returned to respondents in the second round. Respondents were also given a summary of all the comments of the other participants, so they had access to the argumentation of the rest of the group. After the second round, comments provided by the respondents revealed that all criteria were well understood, So dissensus and consensus criteria were accepted and no new round was sought. So who participated in the Delphi? We had 53 psychiatrists who completed round 1 and 47 who completed round 2. The mean age was 54 and about half were female. Most worked in the Netherlands, 21% in Belgium and 4% in both countries. Most had received an assisted dying request from one or more of their patients ever in their career. The vast majority had also performed an independent consultation at some point in their career, but only 23% had actually performed assisted dying due to psychiatric suffering at any point in their career. So in terms of the qualitative analysis of the open question, this revealed some themes related to persistence of suffering, poor prognosis and failed treatments. This inspired 2 new criteria which were added to the second round, and one of which reached consensus and was included in the final criteria. And I'll point that out when I go through the consensus criteria. So these were the criteria that reached agreement after the 2 rounds. There's the diagnostic criteria, and on the next slide, the treatment criteria. I'm not going to read all of these out, but to summarize, a DSM diagnosis and a descriptive diagnosis must be present. Contextual and systemic factors must be taken into account. 2 psychiatrists must confirm the diagnosis. There are limits to the amount of diagnostic procedures a patient must undergo, reasonably undergo. These are the treatment criteria that were agreed on, and I won't read them all out again. I really hope that you will check the article which is at the bottom of the slide for them. But to summarize, all indicated drug and psychotherapeutic treatments in ECT must have been tried adequately. At least one recovery-based treatment must have been attempted. If necessary, substantial efforts should be made to improve the patient's social situation. To give these treatments a chance, the suffering must be present for at least several years. And this criterion was the one that was added from the open question, the analysis of the open question, and reached consensus. And there are limits to the number of treatments that a patient must undergo. So those are the criteria that come from the experts in practice. And we hope that the consensus criteria will be used as inspiration for guidelines, particularly in the Netherlands and Belgium, and that they will be used as inspiration elsewhere. The criteria demand a substantive second opinion by an expert, and we recommend to add a requirement that guards a reasonable position on treatment refusal. Just for practice, they suggest, the criteria suggest that practitioners should ask about treatment fatigue and be careful for hyper-interventionalism. And I'd like to emphasize the importance of not adopting a checklist mentality. So these criteria represent the expert opinion from practice of the minimum and essential criteria that must be reached to establish irremediability, but they need to be used with expertise and within a patient-physician relationship, or as Cisco likes to emphasize, to find a middle ground between carelessness and over-cautiousness. So some future directions for research. Our research was aimed at psychiatrists, but the patient's perspective is of course very important and warrants more attention. We'd recommend to repeat these studies in Canada, other jurisdictions, other countries, other cultures, and further deliberation is needed on this retrospective view of irremediability. And I'll endeavour to answer any questions in the discussion section, but if there are more detailed questions or discussion of future work, then please do contact Cisco.